Hello, my name is Jorge Raúl Zúñiga, and this is my clinical case study. For this clinical case study, I will be talking about intertrochanteric fracture, which is a common type of hip fracture. As a matter of fact, about 50% of all hip fractures are intertrochanteric fractures. They are common on elderly people also. Now, intertrochanteric fractures are complex and require a multidisciplinary approach that involves orthopedic surgeons, anesthesiologists, physiotherapists, and of course, imaging department, X-rays, CT. If this fracture is left untreated or undiagnosed, it can cause significant consequences on the patient's mobility, quality of life, and it used to be mortality, although those numbers have been coming down with the advancements on medicine. In this case study, I will present the case of a patient who suffered an intertrochanteric fracture and the treatment approach taken to achieve successful outcomes. The patient in this case study also suffered a humerus fracture, but the focusing will be on the intertrochanteric. And my intention is to highlight the importance of imaging in early diagnosis, also alternatives to positioning and tube angles to obtain the necessary images for the diagnosis, and the collaborative approach to manage intertrochanteric fractures. On this case study, also, I want to make sure that I set down the rules. I will talk about the process on how I got the images, the position, and the CR angles that I use. And the images presented are the ones that I actually got. I got provided that they were given to me by the clinical side. So I don't have every X-ray that I'm going to talk about or present, but I will have most of them, some of them, and then I will define the pathology. I will talk about what it is and how what it happens, and I will also go and talk about what happens in the OR. What's the job as a technologist in the OR and post operation. Now I will talk a little bit about it as well. So the person in this case study is an 84-year-old woman who was admitted to the emergency department after falling at home. Her left arm had a bandage splinter around it, placed by the EMTs. Since her arm, I guess, presented an obvious pathology due to the fall when the EMT or the ambulance got there and saw her. In the ER, the attending physician ordered several X-rays, which are here listed on the screen, which is a left humerus, left shoulder, pelvis, hip, left femur, and a knee radiograph as well. So when assessing the patient at the X-ray room, it was determined to start with the X-ray of her humerus. I saw the splint. I was gonna take the patient. I was talking to her, and I saw the splint. So I made it obvious that I should start there because it was where the pathology was. And actually, I thought it was only on her arm, and the other parts were not gonna show anything. So additionally, we determined to perform the X-ray on a stretcher, so it will limit the patient's movement. And also it was, the first image determines that we're going to start with the humerus. So the first image was taken with an AP humerus, although in reality it's more like a neutral position because the patient, we didn't ask her to move her hand. I placed the IR safely behind the patients, and I angled the tube, and I made sure that I had both the joints on the X-ray. I left the patient semi-erect on the stretchers as well. When I took the X-ray, I saw that it was a positive image. It demonstrated a closed transverse fracture with displacement in the mid-humerus area. The X-ray proved helpful for me because it gave me the guideline on how to proceed with the following images. I knew I was not going to be moving her arm that much at that point. So for the lateral projection of the humerus, I wanted to do a transthoracic projection, right? We put the patient next to the arm and we hold the opposite arm and we shoot through the ribs and all that. We use the orthostatic breathing technique. But the technologist that was in there checking on me disagreed and told me that the best option was to obtain the images, but just by angling the tube and stuff like that. So I did that. I angled the tube, and the lateral view. It's not really a lateral because the epicondyles are not perpendicular, but the image showed a different angle of the humerus. So the tech told me it was basically diagnosable, that to keep it, it was good. But this view and angulation also gave me the baselines to perform a shoulder Y, as you can see on this image here. So basically, I just slightly moved the CR, I moved the IR, and I took another X-ray, making sure that I got the clavicle and the sternal clavicle, the SC joint, sternoclavicular joint. I also use a similar technique to get the gray sheet. So I just an opposite angle, and also collimated to the area. And I got the gray sheet view. Every image, during every image, I assess the patient, how she was doing, how she was feeling. She reported, pain, but not severe pain. So I also did an AP shoulder. It was performed in a similar position that it was used for the humerus before. So, just with the minor CR and IR movements, I got these images without inconveniencing the patient that much. So upon finishing with the upper extremities, I moved down to perform the X-rays of the lower extremities. I started with the pelvis. The X-ray was to be performed on the stretchers as well, and the patient stated that she had no severe pain at this point. So at this point, I carefully flattened the stretcher, providing support to her arm. So the tech came and helped me providing support while I was lowering the stretcher. Then to ensure that I had the CR in the proper placement and don't having to move it once it's under the patient, I first established my center where I wanted the IR to be. And I placed the IR next to her, found it, and then I lifted a little and carefully slid the IR under her, lifting the patient, as I said. I angled my CR. I put it perpendicular to the cassette. I collimated to the cassette, and I took the X-ray. And this is the X-ray that I got here, which clearly shows the intertrochanteric fracture. That's not a perfect hip X-ray because you can see elongation in one side and foreshortening in the other on the pelvis, on the alas of the ilium. But it's the image that we could take, consider the patient, how she was. And you can see here that there is a fracture there. At this point, it was evident that we were not going to be able to have the patient move for a hip, front leg hip, or lateral humerus and stuff like that. So we moved down to the next X-ray, which was the hip. I took the image of the hip. I just moved the CR angle and collimated. I don't really have the image of that hip X-ray. What I got here is basically the proximal femur X-ray that I took. And it was basically the same. So I just moved the cassette, the CR a little bit lower, collimated to get as much as I could from the femur, and I took that one. Then I moved the CR a little bit lower, and I moved my IR also a little bit lower to get the AP of the knee. And for my surprise, when I went and took the X-ray for the AP knee, what I got, it was this lateral X-ray. So when I was trying to get the distal AP femur, I realized that the patient leg was dislocated in a way because instead of getting a distal AP femur, I end up with a distal lateral femur. I wanted to perform for the lateral hip and lateral femur. I wanted to perform an axiolateral inferior superior projection like the Dennis Miller, or a modified axiolateral like the Clemens Nakayama, to get the proximal and lateral femur. But the tech told me just to perform the X-rays on the stretcher, and basically like a transthoracic lateral femur, which is put the stretcher next to the IR, to the wall bucky, and exposing the patient through the side, and we were going to utilize the AEC, the automatic exposure control cells. Now, I understand why now. I understand. Even the tech didn't have to tell me, but I understand and I see why the tech will want me to do, the examinations and the way he wanted rather than the other way. And it's because, it's not about getting a perfect positioning for an X-ray. The goal is to aim to obtain a diagnostical image, no, without inconveniencing the patient, without keeping them too long on the X-ray room, right? We don't want them there for a very long time. The sooner we get done with them, the doctor can read them and then they can proceed to help the patient in the way that she most need at this point. So by using the techniques that the tech gave me, it allowed me to shorten the time of the examination. And, I just had to do a slightly changes to the ER and CR rather than moving the stretcher to do a transthoracic and move it again to do a scapular Y and stuff like that. So that was the thinking, I'm guessing, behind the tech by telling me, don't do a transthoracic, just angle the tube and move the IR slightly. So those are the important things that you can learn in a clinical setting. Just not doesn't have to be like the book tells you because you want a perfect image or a great image. It's whatever the doctor can use, and also help the patient not to be long there. Then the next X-ray, so I went for a left knee, and I had to get the AP. I mean, to get the AP of the distal femur. This is a distal femur of the X-ray here. I had to do a cross table because, like I said, when you do the AP, basically you get a lateral. So I have to do the cross table. And then to get the images of the knee that the doctor wanted, we only sent 2 images. It was requesting 3, but the patient obviously was not be able to do a sunrise or oblique the leg. So we just took the lateral knee and the lateral in the AP knee, and we just the same. When I took this cross lateral AP for the femur, the distal femur, I just lowered there a little bit lower, actually lowered the stretcher to be more on the knee and collimated to the knee in shot for the knee. I don't have that X-ray, and the same for the lateral, which I also don't have the X-ray for that lateral. And that was the finishing of what we were doing with the patient to do that. So now I want to basically talk about intertrochanteric fractures, which is a specific oblique type of hip fracture that occurs below the femoral neck between the greater and the lesser trochanters. And it can be a single or multiple fracture. As far as the patient in this case study, as you were seeing on the X-ray before, it was evidence that beside the intertrochanteric fracture, the lesser trochanter was fragmented. It had an avulsion fracture, like the tendon is pulling. You can see here on this one, you have the intertrochanteric fracture, and here the lesser trochanter is separated. So maybe it's an avulsion fracture. The tendon here is pulling the bone out. It's kind of similar to the cartoonish drawing that I have here. So this type of fracture usually occur due to in an elderly person, as I have said at the beginning, and it happens because of falling. Most of the time, it's because it's falling. These fractures can be classified in two different ways. Can be a stable fracture, which is kind of the picture, cartoonish picture here lower, which is it's just like you have the fracture, but you don't have displacement and you don't have any other fractures on it. And it's and the unstable, which is the patients that we have where the knee is oblique and the leg is not, the anatomical structure of the leg, the femur is not right. As I'm telling you, the patient's characteristics in my case study, it was as a type 4 intertrochanteric fracture, and it was unstable. And it means basically that the way to treat it is through surgery. And the surgery basically is one of the most common type of surgeries called ORIF or ORIF, which is open reduction and internal fixation. So during the procedure, an incision is made on the hip area to gain access to the femoral head. The fractured bone fragments are then repositioned or reduced back into their proper alignment. Once the bone is aligned, the internal fixation devices such as screws, plates, and wires are used to hold the bone in place, and the doctor then stabilizes it. Now, the technologist's job during the surgery is basically to assist the orthopedic surgeon with the floor that he requires. Now, what the doctor asks you to do, the surgeon asks you to do will depend. It will vary from surgeon to surgeon. So some of them will want lateral images and AP images. However, when I was with this doctor in this case, he wanted only AP. Basically, the only things that I did was an AP view of the hip and an AP view of the pelvis and such. So the job started when the surgeon requested an X-ray, an image. He asked for fluoro, basically to mark the site of the incision. I guess he put the tool there, so it was showing on the X-ray, and then he managed to put it in an angle that he wanted to do the incision. Um, then he will continue working. Then he will ask for fluoro again, maybe to position in the guideline. So he will position the guideline. He will ask for X-ray, and that's basically how he's guiding to insert the rods on the femur. Then he might ask for more images as he's hammering the rod into the bone or placing the screws. He might ask for images at that point. In this case, he did once or twice, but not really too much. After I did the positioning for the guideline, I just stood there, and then he will ask, for fluoro or X-ray in certain area, and it was just for the guidance. But I maybe did three or four X-rays during that moment. So close to the end of the surgery, the orthopedic surgeon in this case asked me he asked me for images as he moved the patient. So he will grab the leg and move it to one side or the other one. And every time he moved the leg, he will ask for a picture, and he will ask to save those images. So I'm guessing he needs them to make sure that the movement is proper during after the surgery, so that the parts that he placed are functioning properly. The last image that he requested was kind of weird for me because I don't know this stuff, but it was basically he put a ruler in between the symphysis pubis, and it was just to make sure that it's equidistant. So that was the last image, I guess, and just to make sure that it's equidistant, he placed the ruler, and then you do the X-ray, and then it shows, and if it's not, so he did something, and then I don't know what he did, obviously, but then when he asked again for an X-ray, you could see that the symphysis pubis was level um, with the ruler, with the marker that he had placed. So, which it was really cool, and that was the case of that was the end of the OR. Basically, this point, the patient goes to recovery, and the doctors will ask for a couple more images. So after the surgery, and this is the case. This was the AP post-operation. They will also request a lateral, usually the two views of all the prostheses when not implanted. So at least in Holy Cross, so you will get the AP and the lateral of the knee. If it was a knee replacement and things like that. So in this case, you have the AP hip, and then now you have the cross table, the lateral for the hip. The end for our patient is recovery and physical therapy to go back and have a normal life, as we had said at the beginning. And to conclude, just X-ray images, I wanted to make sure and highlight they play a crucial role in diagnosis and management of the intertrochanteric fracture. We provide valuable information and location and severity of the fracture. In X-ray technologies, it's imperative to understand that the relationship between anatomical structure and how the CR angulations will provide the necessary views. Like the CR angle, if you know that you need to split the radial head, and the patient cannot externally oblique, maybe you can oblique the CR, and those things come unhelpful. So if you know that the Y is by the patient moving, so you angle the CR rather the angle of the patient or the stretcher of this case. So all those as a tech, it is important how to know how the anatomic structure function and are in relationship to each other. Intertrochanteric fractures represent a significant clinical challenge that require timely diagnosis and management, and a collaborative approach, like I said, and we play an important part, and we are the first ones to provide the doctor those images. And the faster we do this stuff, the faster the patient will get the treatment that they need. And being fancy and trying to do cool positioning that you learn at school might not be sometimes the more logical approach to this stuff. I hope you have learned something, and thank you.